week. We're going to turn it over now to today's webinar leaders, which are Kate Cooper and Chris Mayhew. Kate and Chris are senior consultants with our engagement and patient experience team within Quality and Healthcare Improvement. Their presentation is titled Building Patient and Family-Centered Partnerships. In the presentation, Kate and Chris will explore some of the foundational concepts related to PFCC partnerships, identify directions and opportunities within AHS for partnering with patients and families, and share some real practical strategies and actions to build environments and interactions that foster partnerships. With that, I'd like to welcome Kate and Chris, and have a great webinar.
Thanks very much, Lynette. We appreciate that. So, Chris, I'm going to hand the mic over to you now. Chris is a senior consultant with engagement and patient experience. So take it away, Chris.
Thank you, Sue. So this year's theme, and certainly the theme of our presentation today of growing partnerships, was based on a number of requests that were received and feedback during last year's PFCC week. We'd like to welcome you all to the presentation. We're really thrilled that we have so many on the line today, that so many people are interested in this topic, and we look forward to having the discussion. So we're starting off at the highest of levels, and we're going to say healthy Albertans, healthy communities. These two lines are simple, but they really speak eloquently to the mission of our organization. It really is about our reason for being. As individual citizens of this province, we want health for ourselves and for our loved ones. But we also live in a context. We all belong to a variety of communities, be they geographical, cultural, familial, work interest. However, personally, for me, the most compelling and powerful part of our mission statement comes down to a single word. It's together. Our greatest challenge and opportunity is the extent to which we can work together with patients, families, communities, and each other to achieve health. Together is about how we connect and relate to each other as people, regardless of our title. It's about recognizing the contribution that patients and families bring and actively seeking their input and participation to improve the healthcare system. It is about respecting the hopes, fears, aspirations, and desires that patients and families have for themselves, as opposed to what we may believe or feel is best for them. It is about honoring and valuing that families that care for loved ones for the days, weeks, months, and years before they come into contact with our healthcare system, and who will be there when they return to their homes and communities. To successfully work together, we need to establish and grow meaningful partnerships. In our presentation today, our goals are to explore and to challenge the meaning of partnerships in healthcare, to build knowledge about how to foster successful patient and family-centered care partnerships, and to provide you with practical resources and tools to support you in developing your abilities to grow and build PFCC partnerships. With that, I'm going to pass it on to Kate.
Hi, everyone. So I'm just going to toggle ahead one slide, and I'll come back to that slide on PFCC in a moment. So in order to build partnerships, I think we need to do some unpacking around what exactly do we mean by partnership. We can often take for granted that we use terminologies that we think we have a mutual understanding of what it means. And partnership can mean a lot of different things to a lot of different people. So what exactly do we really mean by partnership, and what are patient and family-centered partnerships? I think maybe a bit of a discussion around how do we achieve said partnerships, and what do we need to know to set ourselves up for success. So we know that partnerships between patients and families and healthcare providers are really about shared goals. They're about agreed to roles and responsibilities. And we're about a mutual benefit for all parties, obvious transparency and trust, active maintenance of the partnership, equality of participation and equity, and meeting agreed obligations. So those are really the essential ingredients of what makes for partnership. And we're starting to do this quite well, I think, on a collaboration level or a systems level, particularly when we're working with patient and family advisors. We have terms of reference and partnership agreements. And if anyone is going to be working with patient and family advisors, I really find that this 7-point sort of elements of partnership is a good tool to use. It's by the Harvard School for Public Health. That these are questions that you really want to scope and answer together to make sure you're on the same page. But it can be pretty hard to translate all of this into point-of-care interactions in time-sensitive circumstances, and it really turns building partnership into a bit of an art and a skill. So what can help us? So I do like to look at the principles, principles of patient and family-centered care. So when we apply the principles of patient and family-centered care, they can help us to achieve authentic partnerships on both the systems level of healthcare design and planning, as well as at the point of care. Respect and dignity, information sharing, participation, and collaboration are the 4 principles, and in case anyone wonders where these come from, they come from the Institute for Patient and Family-Centered Care. So these are the 4 principles that our team really looks to and are commonly used throughout AHS when we're talking about patient and family-centered care. When we treat people with respect, how exactly do we do that? Let's unpack this a little bit further. We greet, we can introduce ourselves, we can explain what's going on and why. We ask people how they wish to be addressed, and whenever possible, we honor patient and family choices, even if we may not agree with them. NOD is a good example of a practice that we use, that's name, occupation, duty, a practice that we use to ensure that we meet baseline for respectful behavior and those initial interactions. Dignity is a little more difficult. How exactly do we treat people with dignity? I tend to think of dignity as acting from a place of recognition, and that's the recognition that people are in a state of vulnerability when needing health care, and whatever we can do to ensure their experience is a dignified one is essential. Comfort rounds is a good example of a practice that can keep people's dignity intact by providing consistent interactions for addressing their comfort and care needs. So looking at shared information, or sharing information. This is the opportunity to really build trust and rapport, and trust is essential for partnership. Was information provided in a way that was useful to patient and family members? Did it alleviate any anxieties or concerns they had? Was the information understood? How did we convey it? Was there an opportunity for patient and family members to offer to us what they think we need to know? And how did we find out? We will get to some ideas a little bit later on about some of the ways that we can work with information sharing that provides that real mutual partnership-oriented communication. So I like to think of these first 3 elements really as the sort of partnership starter. They're essential, they need to be mixed together, and they kind of have to sit for a little while. And once we have, and when we provide care through the behaviors of respect, dignity, and information sharing, it's much easier for patients to feel they can participate as full partners in their care design, and we are much more likely to have a true, authentic collaboration with each other. So what can get in our way of fostering patient and family-centered partnerships? And some barriers are more obvious than others. I think of things like the industrial nature of our acute healthcare system, where a patient can have interactions with dozens of strangers in a mere matter of hours. This is where it's really imperative that implementing some key PFCC practices, such as NOD and whiteboards, are really essential to neutralizing any exasperation of vulnerability or confusion. I also think sometimes about the language that we use. I have often heard, and I have done so myself as well, that we refer to healthcare as a system versus service, and by both, and patients do that as well. And how might our perspective shift about healthcare if we were to use every opportunity we had to switch the words of system for service? It's just an interesting experiment. I've noticed for myself when I do that, I feel like there's a bit more of an injection of humanity into the work that I'm doing, that it is really about providing a service, an essential service that everyone needs, and that we are all in this together. So moving on, other things that we need to really think about and have an awareness about are the impact of our culture. So we need to have a firm understanding of how does healthcare culture, how does it work for creating partnerships and how does it work against them? What does our healthcare culture currently say about partnerships with patients and families? I think it'd be very helpful for us to have more dialogue with our teams about this, identify barriers and assets that we have, things that do get in our way of making partnerships. How do we know when we have created successful partnerships, what assets do we have that we can use to be able to further and deepen the partnerships that we're trying to cultivate? We still have, for example, a great deal of hierarchy within healthcare. How does this affect our efforts? And the industrial model of healthcare, it may limit the time we have to interact with individuals. Are there ways that we might be able to use time differently when we are engaging? For a portion of patients and conditions, maybe partnership is not appropriate or even possible. When this is so, is this really the case? When is that the situation and when is it not? As we know, healthcare needs are really changing. We see a lot more chronic long-term health challenges that require multidisciplinary and collaboration and ongoing relationships between patients, family members, and healthcare providers. Providers and patients are both being held more accountable to their behaviors. We see a lot more public engagement across the spectrum of institutions and services that for the public. And as we know, there's a changing nature of healthcare needs, which is requiring patients themselves to be more engaged in their healthcare and more accountable to their state of health. The leave it to experts is not helping our healthcare providers necessarily design the best health experiences. So we do need partnership if we are to achieve the mutually shared goals of health and quality of life. And we are needing to become exchangers of our expertise, healthcare providers in their technical expertise, and patients and family members in their self-expertise. So when we're looking at culture, it really comes down to beliefs and values. A lot of my work has been around implementing practices that will further patient and family-centered care. But I know that if we have a deep examination of the value and belief that we have around patients and families, behaviors will follow. We can bring patient and family advisors to the table, share stories, and implement patient and family-centered care practices. But for genuine, authentic partnership, asking some pretty deep questions around what are the values and beliefs we have about partnerships and about power, because it is hard to have. You can't really have a true, authentic conversation about partnerships unless we're having an examination of power. And examples of some of the questions we might need to ask are, what do we really believe about patients and families? And for patients and families, what do we really think about healthcare providers and the healthcare services and system? We value getting it right, but do we also value what kind of experience people have had to get there? Do we believe patients and families can teach us things that we really need to know? And what biases do we have that might get in our way of promoting the equality and equity needed for partnership? So for example, in our Digital Story Film Festival, there'll be a film all about that, how patients with addictions have felt at times that they haven't been treated with the same degree of equality and equity needed for their care. And on that note, talking about equality and equity, these are also essential strategies that are needed for cultivating partnership. Equality is about treating everyone the same and giving people the same opportunities, but equity is about giving people what they need to be successful. Historically, medical expertise has trained the public to be quite passive. Doctors know best, leave it to the experts, those kind of attitudes and beliefs around medicine. We've had a hard time adjusting to the model of partnership where a patient and family member is being an equal member of the care team. This is also hard for patients and family members. Sometimes we need to be cognizant that this is also a new approach for many patients and family members as well. And I was thinking back to a story from one of the patient advisors I worked with who had been having many challenging experiences with chronic pain, and when she met her most recent healthcare practitioner she's been working with, he asked her what her opinion of her condition was, and she said she was completely floored that she could even have an opinion. So we're both in this together, and this is a new paradigm for us all. And what do we really mean by equity in healthcare? This picture makes me think of what it can be like to be a patient advisor at a meeting, or a patient or the family member that may have been invited into designing a care plan. So we've created space at the table. The chairs are there. That's the equality piece of it. But if we're only using acronyms or healthcare speak that people can understand, or if we're not making time for maybe necessary explanations for everyone to participate, then we're not engaging in equity and we are not going to be having a true and authentic partnership. So what are some things people might need to be able to participate, fully participate? Language is a good example, so being conscientious of the professional speak we use. Time, that might be something people need with more explanation. So those are just a few of the things to think about when we're looking at equity and equality. And equity being about giving everyone what they need to be successful. We are within healthcare, and as healthcare practitioners, we are the system stewards. And when you're in a position where you're in need of that expert knowledge or that technical expertise, you're automatically at a bit, the equality is not there. The playing field does need to be leveled. So it can really be up to us to extend that hand out to provide an opportunity for equity. Doesn't mean that people are necessarily going to take it, but the goal is to really to create the space to ensure that partnership could be cultivated if both parties are willing to go there. And one of a good example of that might be if we ourselves stop or we ask our colleagues to just stop using acronyms. And sometimes it might be taking a minute to explain the new partnership model that we are moving towards and what that means. And it might mean dropping our assumptions as well about what matters to people and what matters to patients and their families. So with that, I'm going to turn it over to Chris to talk about some of the tangible ideas for building PFCC partnerships.
Thanks, Kate. So now that Kate has established some of the principles and concepts around partnerships, I'm going to speak a bit more about some of the tools and techniques that we all can employ to establish effective partnerships with patients and their families. Our relationships with patients and families are complex and determined by many factors. However, experts do agree that introducing yourself is effective and key to any interaction. As the well-known physician Gordon Neufeld and psychologist Gabor Mate state, the greeting is the prerequisite for all successful interactions. You may be familiar with the saying, you never get a second chance to make a first impression. When staff are stressed and busy and dealing with multiple demands, it's all too easy to shortchange this important step. Have you ever been in a situation where you approach a counter and are provided with a curt direction with no greeting, or perhaps even no verbal or physical acknowledgement of your presence? How did that make you feel? Does this type of treatment create the impression that we are interested in partnerships and that a patient's presence is valued? To patients and families, every member of the healthcare team may appear to be the same. Patients don't always know who you are or what you do unless you tell them. Patient concerns often hears from patients and families that they had no idea who was talking to them. This is where the simple acronym that Kate had alluded to, the NOD acronym, is an effective and reliable practice to start off our interactions with patients and families. And it really is that critical first step in establishing a trusting relationship that can affect and improve the outcomes of any interaction. The language that we use in written and verbal communication can also have a significant effect on our ability to partner with patients and families. The language that is frequently used in our healthcare system, whether or not we always recognize it, is often based on power, ownership, and authority, as opposed to shared responsibility, trust, and inclusion. Take a minute to compare the two signs and also to compare the two columns in the table. And in the chat box, I'd encourage you to type something around the differences that you notice between the terms of the language and approach in the two signs. Just what do you see as the difference, and how does the language and the way that it's phrased make you feel personally? To help us understand the impact of language, what better opportunity than to ask patients and families themselves? Consider arranging a walkabout of your area or a focus group, a meeting to obtain a valuable input into the language that we use in written materials and signage. We also need to think about and shift the language when referring to patients who are not defined by their symptoms, condition, behaviors, or the impact that they may have. As the quote on this slide from Desmond Tutu reminds us, language creates the reality it describes. If we want to create a reality that truly respects partnership, we need to stop using impersonal clinical language that does not foster or respect the relationships that we want to have with patients and their families. I actually have a colleague and a friend whose son was born with Down syndrome and has had frequent interactions with the healthcare system. She herself is a health professional, and nothing frustrates her more than to have her son referred to as Downs or a Down syndrome child. Healthcare staff, with the best of intentions, have said to her directly, Down's babies are so cute, or Down syndrome kids are always so happy. She does not want to have her son labeled and defined by his condition. It's not about denial of his condition, but it is about recognizing him as a person and more with the value and potential than the simple label or illness. With that, I'm going to pass it back to Kate.
Okay, so we thought we'd take a little assessment together on our rapport and rapport building and communication skills. So I'm going to pull this over here. So talking a bit about active listening and what is active listening. Really it's about when the listener uses their body language, tone of voice, word choices to help the speaker feel heard and understood. And I want to pull over this poll here. Oh, so Sue, poll number 1. Thank you. So what is a key indicator that someone is actively listening to you? I always find these interesting because you can often tell who might read the whole thing first. Yeah, and we can see there everyone has had a chance, most people have had a chance to read it through, and it's true. All of the above are really good examples that someone is actively listening to you. One thing that's an interesting trick, and one of the biggest clues, is when someone you're speaking with, their head is tilted slightly. If you're having a hard time listening to someone, I actually suggest try tilting your head, and you'll find your attention will actually, your physical body will then want to make your attention focus more. It's a really it's a key trick to help cultivate more active listening, which is of course needed for rapport building. Thanks, Sue. And moving on to poll question number 2. Okay, what is not a benefit of active listening? We often think that active listening would be really good and we should do it all of the time, but there can be some consequences. So I'm just curious about what people might think is not a benefit of active listening. Yeah, and there we go. People often assume you agree with them. So if there is something if there will be consequences of someone walking away from an interaction with you, we need to go back to that pillar of partnership, which is about transparency and finding ways of how we can show people that we are actively listening to them, but we do not necessarily agree with them, or vocalizing something that's important for us to say. Thanks very much, Sue. And poll number 3. So I've been trying to practice, and in a lot of the work that we do, practice asking questions and designing questions and creating some scripts and some ways that we can have questions that really are engaging. And so I wanted to ask here, what are some of the types of questions that we maybe need to be using with caution? Yeah, that's right. Closed and leading questions. They both have their place, but if there's other ways of us being able to collect the information, we should possibly examine those, or we should examine why we're using said questions. So thanks, Sue. We can take that one away. So this is just one of the tools that we have. The art of asking great questions does take practice, and I do encourage having taking one set of questions, and so maybe reflective or effective questions, and practice them throughout a day. Find opportunities to be able to use them, and you'll see that your rapport building skills, they really help to heighten them. So let's look at poll number 4. just curious here. This is a bit of an assessment around how many of you might know or be familiar with TeachBack. Yeah, so actually TeachBack, actually Sue, can I pull up this next slide here? And I'll put the slide up for them. So TeachBack is a tool that is about, it's all of the above there. It can be used to help people know what needs to happen with their treatment, what will happen when they are discharged, and any follow-up instructions that they might have. And the objective of the tool is the objective of, I guess, the practice is really to have people explain to patients and families what it is that is needed of them, but have them clarify any misunderstanding before moving on, and then have them describe back what it is that's necessary. And then the big keys about this is if there's any misunderstanding or things that need to be clarified, the onus will be on the providers to really find a way of explaining it differently and not just constantly going back to the same use of language. And with that, I'm going to turn it back over to Chris to talk about some more great things that we have going on that can help with us building patient and family-centered partnerships.
Thanks, Kate. So now that we have introduced you to quickly to a few ideas, and there's certainly many more out there, but a great place to start in terms of your journey about improving the way that you communicate and build those partnerships with patients is to understand how you're currently doing and to be able to identify the strengths and opportunities that you have for improvement. We actually have a couple of assessment tools that can be used to help you and your teams. The first one is the Patient and Family-Centered Care Assessment Tool. It's actually the visual that's on the screen here. And actually both tools that I'll be talking about are through the hyperlink that you see on this slide, and it will actually be included as well. The Patient and Family-Centered Care Assessment Tool is really intended to create a deeper understanding of PFCC principles and practices, and to assist areas to assess themselves in regards to PFCC behaviors. It's really to help facilitate identification of PFCC goals and then to support the creation of PFCC action plans. This tool can be used by anyone, although it certainly is intended and it's valuable to those who are responsible for setting the direction, priorities, or activities for an area within the organization, that is for a program, service, or unit. Once the assessment is completed, there's an action plan template and tips and ideas that are included in the tool. The second tool I wanted to describe is the Voice and Choice tool. And the Voice and Choice tool is another tool for teams and for self-reflection of professional practice for person and family-centered care. It was actually developed by the Health Professions Strategy and Practice Group and with the support of our Engagement and Patient Experience team. For this resource, teams or individuals reflect on the key principles and ideas and concepts around patient and family-centered care. This then can be used to start a conversation, set goals, and spark ideas for actions. You may actually want to use this tool as a part of a reflection for your own personal performance review or professional competency assessment. So both of those tools can really be helpful in trying to establish that baseline for practice. The next topic that we want to move on to, and switching gears a little bit, is around the Accreditation Canada focus on client and family-centered care. For those of you that were involved in the most recent 2016 accreditation survey and going forward, Accreditation Canada has introduced a focus on client and family-centered care within their standards. These standards align nicely with the organizational focus on patient and family-centered care that has been established through our own patient first strategy. And in those, Accreditation Canada has included two important distinctions. The first of them you'll see is with input from patients and families. And this really speaks to engaging with patients and families to seek their input into the planning, development, implementation, and evaluation of healthcare services. This can be achieved through a variety of mechanisms such as focus groups or surveys, advisory councils, etc. The second approach is in partnership with patients and families, and it refers to the collaboration between the healthcare team and with each individual client and family in the delivery of services at the point of care. AHS accreditation team and Engagement in Patient Experience have developed this resource and links to other supporting resources that can help provide you guidance in your accreditation process. The document that you see in front of you now is actually a really excellent resource that we're pleased to introduce today, and it's been developed within AHS and is really aligned, of course, with what we're talking about. The Principles for Partnership is a one-page document that outlines the roles and responsibilities of patients and families and care teams in collaborative care. The goal of the document is really to define the common behaviors in collaborative patient and family-centered care. It's about creating recognition around the respect of the rights of patients and providers. And it helps describe the commitments that we all have within the collaborative care team. It facilitates communication, helps to create clear expectations and trust among patients, families, and providers. The creation of the Principles of Partnership document was adapted from the National Patient Safety Foundation Universal Patient Compact, and it was developed within AHS by the COAC team in partnership with Alberta Health Services Provincial Patient and Family Advisory Group, what we sometimes refer to as PFG. The current version is actually a result of 3 rounds of revisions with the Provincial Advisory Group. And it was developed because AHS doesn't currently have a patient bill of rights. It certainly aligns well with the provincial Alberta, or with the Alberta Health Charter. So the opportunity for this document, for adopting this, is certainly to create a standard and help us maintain trusting, strong relationships between patients, families, and their healthcare teams and support. Through this visible tool, we're able to commit our organization to a high standard of patient and family-centered care. The next topic that I want to speak to is around balancing technical expertise with emotional competence. And the quote is really meaningful, and I think can probably express it well, is that patients won't care how much you know until they know how much you care. Certainly in our healthcare system, and understandably so, we do have a bias towards technical expertise. And of course this is important. It's really a key part to why people obviously come and interact with the healthcare system. But sometimes what happens is that we devalue the development of emotional competences which are really needed for partnership. We need to have a balance between that technical competence and emotional intelligence, and because we know that relationships affect outcomes. So supporting partnerships with families and other care team members is equally important as the technical expertise that we bring to a situation. A resource that can help with this is actually the Patient and Family-Centered Care Question Guide. This is a guide that was developed and is intended to help in the interview process, because we know that the interview is the first step in evaluating employees who demonstrate commitment to patient and family-centered care and want to build this culture within the organization. So this resource was actually created to support managers in the assessment of a candidate's fit using the patient-first strategy and the 4 principles that Kate had covered of patient and family-centered care. So it's organized by respect and dignity, information sharing, participation, and collaboration as the framework. This resource, as you can see from the link, is available for potential interviewers to choose from a variety of questions that can help them assess where candidates are at in terms of their knowledge and expertise. Another resource that we just wanted to expose you to, and some of you maybe have seen this previously, but if not, this is referred to, we colloquially refer to it as the wheel. It's called The Voice of Patients and Families, and we often share this in our interactions during consultations with a variety of groups in the organization. It really outlines a lot of the mechanisms that are available to obtain patient voice and the family voice in our system. And it's categorized into sort of three key areas. So the first one being collecting feedback, the second being real-time encounters, and the third collaborating at the planning table. So as you can see from the different sections that you may be familiar, you may be using a number of these techniques, but oftentimes when we share this with people, they really start to see the opportunity for gaining meaningful input. And some of those things are quite accessible. You know, some of them we may need to do a little bit of work and build capacity to get there. But you know, we're certainly, just as an example, of course, we're talking about the digital film festival that's coming up around patient stories, and narratives and stories are an important opportunity to collect feedback from individuals. We have concerns and accommodation data that's available in the organization that can help give us ideas and directions about opportunities for improvement. Within the real-time encounters, of course, you know, it's a big area, but it's around the interactions at the point of care and refers to a lot of the interactions that we've been discussing today about how we can make those more effective and more engaging in terms of partnering with patients. And then we have the formal collaborations that occur, such as patient and family advisor roles. We also have patient researcher roles within the organization, and participation of patients in other committees, such as quality committees and family councils. So with these different techniques, EPE has a number of resources available online that help to describe and give people ideas about how to start these processes to bring greater input of patients and families into the decisions that we make. I wanted to draw your attention as well, and this will just be brief because we are, of course, having a full presentation on this. Hopefully a number of you are signed up and will be participating in the Leadership Rounding presentation that's occurring on Wednesday. Leadership Rounding is a technique that's been endorsed through our Patient First strategy, and of course is also being supported during Patient and Family Centered Care Week through the Leadership Rounding Challenge. You can access information about the challenge at the link, and really it's that opportunity to create conversations and dialogue between leaders and patients and families at the point of care. Sometimes these interactions are difficult, or you know, it can be perceived that we don't have enough time to initiate those conversations, and yet they can be extremely valuable. You will hear on the presentation on Wednesday a number of the techniques and individuals who are currently practicing this within AHS to see how beneficial this approach can be. To be able to have that connection for leaders is proving to be very meaningful. It's a way of connecting with patients in a way that they may have lost, and so we would encourage you to take up the challenge and to attend the webinar on Wednesday. Another resource that we wanted to share, and that's been being promoted during Patient and Family Centered Care Week, and Lynette kindly referred to it during the introduction, is the partnership tree. The partnership tree is a technique that has been utilized within AHS in other contexts, and we've certainly taken that and tried to promote it to a greater audience. It really is a visible way of gathering input from patients and families and staff and demonstrating commitment to PFCC principles and practices. So the value is having a visible commitment, being able to see and create opportunities for people to have a voice. And beyond that, certainly looking at how does this information help us improve our healthcare system, not just during PFCC week where it makes for a nice display or discussion piece, but really how do we continually use this information to help us improve the way that we partner with patients and families. So we actually had set up here in Edmonton a partnership tree in the main lobby area. Of course, we had of 7th Street Plaza, and we had a number of AHS staff, of course, in corporate services, which brought some unique perspectives. But we also had patients walking through the lobby that we were able to chat with as well. And it really was enlightening to hear their perspectives and the opportunities that they saw for improving the partnerships that we have. These resources are available through our PFCC website. So if you go on the PFCC Week, you can access information about how to print off the materials. If you wish to order a large poster, you can do that as well, or you can simply create a poster of your own, even if that's a barrier, and certainly print out the leaves for your use. But it's a great conversation starter, and really can be an ongoing source of valuable information. So with that, I'm going to pass it back to Kate.
Thanks very much, Chris. So could we pull up the last poll here? And this is really for our information. Based on what you've heard today of some of the ideas that can cultivate some techniques and approaches that can cultivate partnership, which ones would you be most interested in using? Great, thank you very much. Yeah, the art of asking great questions. I very much enjoyed practicing with that, and I think that you will too. All of the resources will be made available. They're accessible currently through our website, our PFCC webpage, or they'll be available. We can send them out after this presentation. I had a couple of questions in the chat box around how the partnership tree works. There's an information page available on the PFCC Week webpage on Insight, or if you do want more information, feel free to give me an email, or Chris an email, and we can find out for you. So Chris, maybe could you pop our emails in the chat box there for everyone if they want more details. And just to also mention, someone brought up an ongoing challenge about overcoming significant language barriers, and I saw it pop up here. We're talking about that on Friday on Do You Understand Communicating with Limited and Non-English Speaking Patients. There'll be a presentation on that on Friday. That's one of the webinars that's coming up. And we do have, these are the rest of the presentations that are available throughout the week, registration access from our webpage or from the program guides that we have sent out. So with that, is there any, we'd like to open it up for any conversation or questions, and we'll take it from there. Or feedback. We like feedback too. So we could talk about with the partnership tree. You can order them. So they have Data Group, our printing group, has created templates for them. And you can order them, and there's 2 different sizes. And then you can order a package of the leaves. And it's not as cheap as we'd like it to be. I think the prices are up on our page, Chris. I don't know if you know them off by heart, but
I'm trying to recall myself. The other option, sure, as well, of course, is that we actually have the templates that are available on the website, so you can actually go and print off the leaves yourself, as opposed to sending them for printing. If you're looking to have the poster this week, it might be a bit of a challenge, although you may get delivery if you ordered right away before end of week. That would be sort of at the discretion of data around the trees. The leaves actually take longer, in fact, for ordering, but nonetheless, if you're looking at this as an ongoing resource, you can do that. The other thing too is that, in terms of if the pricing is the issue, simply get yourself a large piece of poster size and draw your own tree background on there. That's essentially what it is, and then use the print off leaves. But really what the goal of the partnership tree is to open conversations and create opportunity for input. So, we provide each person with a leaf and pose a question that has potential meaning to your area. There is a description on the website as well about different ways that you could use the partnership tree and different questions that you might want to pose based on your area. In the example that we happen to use here in the tree that we'd set up here, it was simply the question of what can you do to grow partnerships? and it's a fairly wide open question, but it was intended to appeal to a large audience and really try and create some commitment about what it is that people want to do to help improve the partnerships that we have with patients, families, and our health system.
Thanks, Shelley. Any other feedback or thoughts? Hi, Tamara. So the website address we have is you mean the web page for Insight or for our external page? We should just pop both of them up there. Might be best. I'll grab our internal page here and pop that up. So this is the page to our department, and I'll also pop up our page here for PFCC Week. And the PFCC assessment tool, that's up on the PFCC page, Joanne. Thanks for the feedback on it being insightful. And I'm just noticing the comments here about tips being useful in reception position. A lot of the presentations I had done last year were to ambulatory clinics with both clerks and front desk staff, and you can never underestimate the power of a greeting to already begin to de-escalate frustrated patients who might be arriving, pretty already in a state of frustration, having dealt with parking and travel and all of those other things. So the greeting can really increase people's confidence in the competence of care that they're going to receive. Great. I'm hoping that some of the information we provided is it doesn't just spill into work. I've noticed that it's certainly all reflective and all very relevant for just my rapport and partnership approach in life in general.
Kate, it's Sue here. I'm just looking at Joanne's comment about tips or use reception position. She actually had prefaced that by saying that in some cultures men don't talk to women. Usually they have women with them who talk for them. Mm-hmm. I was just wondering, is there a key place someone could go to find out about what to expect? And because I can imagine that would really impact how we as healthcare professionals perceive them, but also we want to make sure that we don't unintentionally, I don't want to use the word insult, but offend someone by not responding in a way that's respectful to them. Mm-hmm. Do you have tips or information where someone could go for that kind of help?
Well, I think that this is something that's come up. I think more and more is coming up more and more. And attending the webinar on Friday with Louise Beale, who's the manager of translation services, she'll be able to provide some insight in how some sites are handling similar circumstances. I do think there are ways and options we can navigate that. And in terms of partnership is not necessarily, as we know, it's not about, and patient-family centered care is not about always doing what patients and families tell us that they want. It's about us being able to articulate to each other what we need from each other and how we can best, what options we can go about seeking to be able to make sure what each other needs is met if and when possible. So I do think that we have some resources for dealing with that, with those types of concerns in really challenging circumstances. This is also going to come up, I think, a lot more with family presence as we move into looking to promote and help foster family presence across the province. So if you can attend the webinar on Friday, I think that's really good, and I'll also find out from Louise if there's any specific resources we could make available. And with that, I'm going to think I'll turn it back over to you, Sue, because it's 4 minutes to.